Roger, thank you so much for being here with me today, and I appreciate you taking the opportunity to inform me and certainly many others around the issue of trauma and trauma-informed care. So I'm going to start out by just asking you, how did you become interested in having the issue of trauma, let alone trauma-informed care, be a part of your career?
Well, Sue, I think I started actually back in 1974 when I was at the VA hospital in West Haven, Connecticut. It was a time of turmoil in this country, of course, after the Vietnam War. It was just winding down, and we were getting a lot of vets back from the war. And I noticed a lot of trauma experiences they were bringing back with them. It was very difficult, though, to conceptualize what was happening to them. I remember one guy was diagnosed with a stomach cancer, and his condition was very grave and very serious. And it was clear that he had been affected deeply by the war as well. And what we did with that was sort of silly, I think, in retrospect. And we treated him as if he were depressed only. And we didn't take into account the trauma he experienced in the war. So it's more the absence of trauma, thinking at the time, that in retrospect has influenced me a great deal.
Wow. So you're talking even before, as a society, we embraced even the diagnosis of post-traumatic stress disorder, because that was, what, 1980?
That's right. That's right. We didn't have PTSD available to us as a diagnosis at the time. And when it did become available, it was sort of thought of as something you either got over or you got PTSD. Trauma was seen as sort of an all-or-nothing response. Clearly, since then we've learned that it has many, many other implications.
So, Roger, certainly we're aware, and many are aware of the fact that you are one of our key leaders in our country, in our world, conceptualizing the idea of what we call trauma-informed care. Can you speak to how that term, that idea, that conceptual approach is different than, let's say, considering just PTSD?
Sure. It's really a global idea, I think. It's an idea around the shaping of a culture of service organizations, at least, and if not communities at the largest end of things. It's a way in which we thought about trauma as a life-shaping event. It's the kind of thing that people really understand as having before and after in their lives. And it's very important, therefore, to consider the cultures that are responsive to that event or events in their lives. Because very few people come in with one traumatic event. As you know, in this world, the fact is that most people have many traumatic events that have affected them over the years. One of the things we did, I think Maxine Harris and I, when we were talking about trauma-informed care the first time, I remember very distinctly, we were sitting in her office talking about a woman who had been involved in a TREM group, a Trauma Recovery and Empowerment Model group. And after the group, she had gone back to her substance abuse treatment center and had been roundly chastised for chewing gum, an event, an activity for which she had gotten roundly praised at the TREM group. And we thought, boy, there's a disconnect here. And we thought, if we can't all be on the same page with this approach to trauma, then we're going to constantly be working against each other. And it became clear that we would need to develop a model that was shared by both substance abuse and mental health organizations, at least, if not behavioral health in general. And we came up with the idea of being trauma-informed as a shared philosophy of approach, if not a trauma-specific approach.
So I certainly, for our work over here in Buffalo, we have been highly influenced by this idea of trauma-informed approach. However, with that being said, how have you seen this knowledge influence both your work and the work of others?
Well, in my own work, it's been seminal, clearly. It's been a part of my work for the last 15 or 20 years now. It's shaped everything I think about, pretty much from a trauma-informed care perspective. I think of it as a real trauma lens I put on, so that I see everything from a trauma-first perspective at this point. and it forces me to think in terms of what has happened to someone rather than what's their problem or what's wrong with them. And it's a key shift in terms of my relationships with everybody. I assume now that everybody's doing the best they can with what they have to work with, rather than that they're trying to manipulate or get over on me or that kind of thing. It's a very profound shift in my relationships with people with whom I work, as well as for organizations with whom I consult, because they've really taken this on, I think, in a major way around the country. And it's gotten to be a major part of my work to consult with agencies and organizations that want to become more trauma-informed. They have made shifts that are very striking in terms of their safety, trustworthiness, choice, collaboration, and empowerment, which are the 5 core values of trauma-informed care in our perspective. Safety, trustworthiness, choice, collaboration, and empowerment. And they've made their organizations safer, they've made them more trustworthy, they've maximized choice, they've maximized collaboration, they've maximized empowerment for both consumers and clients and for staff. The staff piece is something we've added most recently, I think, and has become a very important part of what we've been doing. That is, initially we were focused entirely on the experiences of consumers in these agencies, and wanted them to feel that they were safe and they could trust people with whom they were in contact and that sort of thing. And what became clear after a while was that unless the staff similarly felt safe, they could trust their supervisors and administrators, that they had choice about the way they went about their day-to-day work, that they were collaborating well with each other and with their supervisors and administrators, and that they were empowered to do their jobs well, that they could not create a sort of atmosphere of trauma-informed care for the clients that they were serving. So we've since then focused about equal time on staff as we do on clients and consumers. Has made a major shift in our organizational approach to this work. It's very important, I think, for us to see that everybody needs to be on the same page and everybody needs to be in the same boat. So we're all rowing in the same direction.
So I actually am sensing the excitement as you talk about this, and actually that's been our experience too, in regards to folks in Western New York that have begun to really consider both things of what you're talking about, considering the idea amongst the clients we work with, but certainly from an organizational culture perspective, how is it impacting each other in terms of our staff? So as we think about this, and Roger, as you think about the influence of really your and Maxine's brilliance of putting this template, if not philosophy, together, what are your best hopes for your work in regards to how it will influence service delivery?
Well, my fondest hopes are that it will continue to be increasingly pervasive, as it has been recently. I think it's really caught on. The National Center for Trauma-Informed Care is a part of that, and the places like ITTIC have been prominent as well in promulgating this approach, and among others, becoming more trauma-informed is a really important idea. And my best hopes is that more and more agencies and organizations in this country and around the world actually will get involved in this process. I was interestingly invited to Hamburg, Germany next spring to talk about trauma-informed care at a conference of trauma experts, and was told in advance that they don't understand trauma-informed care there. It's a new idea to them, and that's exciting too, to be able to take this to other countries as well.
Absolutely. So when thinking about then, as you mentioned, the Trauma Institute, ITTIC, certainly we're aligning with part of what your best hopes are, that the more we're able to, first and foremost, inform others about the fact that trauma does impact and does influence the way that we do business, and the more aware we can be of that, certainly we can allow all of us to be in a position of not certainly making anything worse for people. And so when we think about service delivery systems, I'm thinking back to the gentleman that you spoke of back in 1974. The individual came in with a medical issue. So do you see this approach as being something that can be utilized in all service delivery systems?
I do indeed. I think it's very important in all service delivery systems to be aware of the impact of trauma on people's lives. We're especially seeing it in medical settings now because of things like the ACE study that have demonstrated so clearly the connection between adverse childhood experiences and the impact they continue to have years and years later on people's chronic health conditions. And that sort of finding is, I think, carries a lot of weight in medical settings, and it should carry a lot of weight because we understand very clearly about the ways in which people have tried to cope with their trauma in their lives and the ways in which their coping mechanisms have turned out to be deleterious to them in the long run frequently, and that's left them with chronic health care problems. So it's something that everybody can be involved in, should be involved in, I think. Schools, justice system, the primary health care, and especially health care organizations can certainly be part of it, as well as behavioral health.
Well, thank you. Is there anything that I have not asked you about that you would think would be important for us to touch base on here?
Other than the fact that the broadest expression of this work is starting to take shape in communities like Tarpon Springs, Florida, has trauma-informed care community, and Rockland, Maine, and San Mateo, California. They are all areas that have started to make inroads to becoming trauma-informed as a community, trying to create safety and trustworthiness for everybody involved.
Well, Roger, as always, thank you so much for your time. We so appreciate that you are part of our expert advisory panel in helping us think about our work forward. I know that we will be in touch soon.
Thanks, Sue. I appreciate it.